The first talk was on double autologous transplantation in multiple myeloma. The concept of double autologous transplantation was introduced in the 90s, mostly by the group of biology in the United States, and the objective was to increase the complete response rate and, of course, complete response duration. Initially, my group, the IFM, demonstrated that double transplantation were superior to single in terms of event-free survival and overall survival. But 3 other studies were not that positive, showing at maximum only an increase in the event-free or progression-free survival. This was before the introduction of new agents. So already at that time, some groups started to say, is it so interesting? It's very cumbersome, it's a little bit dangerous, so maybe with new agent we would not need more the double transplantation. So the first information we had came from retrospective analysis of studies testing new agents. And when comparing single and double in a retrospective manner, Dr. Cavo showed that double were superior mostly for patients who did not achieve a good result after the first or who had a very aggressive presentation with poor risk cytogenetics. So we needed randomized trial. 2 were performed, one in Europe, which showed that double transplantation is superior to single transplantation in the era of novel therapy for patients with high-risk cytogenetics, confirming the retrospective analysis. The other comes from the United States and compared after 1 transplant, 2nd transplant, consolidation with new agent, and maintenance. And in the 3 arms, all patients received maintenance. So basically it was maintenance alone versus double transplants plus maintenance or consolidation plus maintenance. And unfortunately, there was no difference in the 3 groups as regard progression-free survival and overall survival. So currently, we don't really know the place of double autologous transplantation, probably only for patients with high-risk disease. But I do think that the most important for the future will be to look at minimal residual disease after the first autologous transplantation. And since we now know that minimal residual disease negativity is associated with a better outcome, I think that after autologous transplantation, the decision might be helped or guided by this minimal residual disease assessment. If it's negative, you can go for only maintenance. If it's positive, you can try and achieve a better result with some form of consolidation, including double autologous transplantation.